So first of all, welcome everyone, and I'm delighted to have the panelists join us for an important topic. So we will be discussing how we can enhance healthcare equity through the provision of accommodations to patients with disabilities. And I'm delighted to have several awesome panelists join us here and share their experiences and expertise and really help us to move the needle and truly make healthcare accessible for people with disabilities. So first is Matt Galvan, who is our Senior Diversity Representative here in Michigan Medicine. Alice Gossage is an Executive Director with the Disability Network here at Washtenaw, Monroe, and Livingston counties. Megan Marshall, who is our Deputy ADA Coordinator, Equity, Civil Rights, and Title IX Office here at University of Michigan. Christa Moran, who is our interpreter, ASL interpreter, also with the interpreter services at Michigan Medicine. She is also the coordinator for Medical Interpreter Training Academy as well. And my name is Mike McKee. I'm associate professor here at Department of Family Medicine, along with Physical Medicine and Rehabilitation, and co-direct with Dr. Michelle Meade at the Center for Disability Health and Wellness. Before we have some questions posed for our panelists, the first thing I want to do is also just give a couple acknowledgements. This really cannot take place with our funding and funders that we have had already established. So the first one I want to mention is NIDLR, which is National Institute on Disability Independent Living and Rehabilitation Research. So we actually received funding to be able to advance health equity for adults with disabilities from marginalized communities. And this is part of our Rehabilitation Research and Training Center. So there is a funding to be able to help not only disseminate some of the findings that we learned from projects and resources. And then the second, we want to also acknowledge Michigan Medicine for funding that was given to Center for Disability Health and Wellness too. So before we ask the panelists for their insights, why do we still have this issue? So first of all, people with disabilities, right now, we have 1 in 4 Americans report having a disability or a limitation. When you really think about the size of the population, this actually would be considered the largest minority population in the US. Despite that, when we think about the amount of resources or effort and attention to these patients is actually inadequate. And what that has done is actually resulted in a number of poor or adverse health outcomes and reduced access. So in this infographic, healthcare access barriers for working age adults highlights some of these gaps that we see. So 1 in 3 adults with disabilities do not have a usual healthcare provider. And there are various reasons for that. Some of it is a lack of trust, a lack of comfort with these providers. Sometimes providers report not having adequate training to be able to gauge them. And then 1 in 3 adults with disabilities have an unmet healthcare need because of costs. So a lot of out-of-pocket expenses. These are individuals that unfortunately struggle with underemployment and unemployment, public insurance, and so forth. And 1 in 4 adults with disabilities did not have a routine checkup. So they are also at risk for lack of preventive services, increasing risk for, in the future, having adverse health outcomes. So I'm going to stop sharing and we'll talk about some of the tools that we have. So for our first question, I want to go ahead, Alice Gossage, on adding a little bit more on some of the gaps that we see for individuals with disabilities and what you have seen as an executive director with the Michigan Network.
Yeah, thanks, Mike. So for folks who don't know me, my name is Alex Gossage. I am a person with a disability. I was born with spina bifida. So I have, I think, a mixture of my own personal experiences in healthcare, as well as many folks that I interact with on a regular basis in our community. And I think, just to put it simply, there are a lot of folks I've met over the years who have some level of distrust of people in the medical community, and I think the easiest and best way to build that trust up on those individual relationships is being able to establish good communication and making sure that the patient is being heard and that they're feeling valued. And so when we're starting to talk about accommodations, that's something that really needs to be talked about at the very beginning, before an appointment even happens, before somebody's in the medical facility. So making sure that if accommodations are being asked for, they're being discussed openly and I think thoughtfully when an appointment is being made, or when there maybe is somebody calling to ask questions. And those pieces are really important because I think when folks with disabilities are feeling like they're not being heard, or their needs are not being heard, that's a concern, and they're not willing to possibly share other information going forward. And this could be as simple as, um, uh, it could be, well, it could be a lot of different things, I suppose. But um, I was thinking about different interactions that happen on a regular basis where accommodations could possibly be easily met, both for building trust, but also just for helping folks maintain their health. Sometimes it might be having a wheelchair scale available, or some way of helping somebody weigh themselves that they don't have access to outside of that facility. Oftentimes, if I go in on my crutches or something like that, because I can walk to some degree, I don't even get asked to go on a scale, and I just end up being asked if I know an approximation if I wait. And on some level, that's the wrong thing to do, just because there's so many different issues related to weight that could be an issue, and I'm just being asked to approximate it, and who really is being accurate with their weight when they're asked. Um, but it also comes to other issues of people needing accommodations and proper accommodations. Might be transfers and how to do a transfer properly. Some folks need Hoyer lifts, but there are a lot of people who don't want to use a Hoyer lift. They know how to get transferred in a way that works for them and their body. And maintaining and learning about those kinds of accommodations are really important. Again, it's about building trust. It's about feeling heard and feeling validated and feeling like we're getting the same experience that anybody else would be, and our health is of equal importance to anybody else.
Thank you, Alex. Would anybody else like to provide additional insights here? Christa.
Yeah, just to piggyback on what Alex is saying, as an interpreter in the system for the past 18 years, there's the whole intersectionality too. So I work with patients that are deaf, but they might also have mobility issues. They might be using crutches or a walker or a wheelchair, whether it's a power wheelchair or a scooter. I mean, it can be any of those things. And at the same time, I'm also in all the different clinics. So I can tell you in these 18 years, I've never seen two patients that have the exact same need. And so I think that a lot of times people think, oh, wheelchair means X. And it doesn't. And maybe on any given day, it might be something different for that patient. So I wanted to emphasize what Alex said, is to ask the patient what they need. Do you need me to push you, or do you need assistance with transfers, or how can we assist you with transfers? Again, having that conversation beforehand, but again, not making any assumptions, because it really is not, just like every single person is different. Every single person with a disability is different. And even that individual, depending on the day, might have a different need. So really, truly, that conversation is so critical to making sure that that person feels like they belong, they have access, they're safe, and that they have a positive experience. Those are all those base priorities that Michigan Medicine has set forth as a strategic priority.
Thank you so much, Christa. Megan?
Yeah, this is Megan speaking. I just wanted to add on to Alex's and Krista's points, just to say that I think what's also really important is also in the sense that there's a gap in this, I believe, from my own personal experiences as someone with a disability myself, and from those individuals I work with, is allowing spaces for that advocacy and for that self-disclosure to take place. A lot of individuals with disabilities are advocating and are needing to advocate for their needs 24/7. It can be very exhausting, especially if you're pushing to find the individual to make that disclosure to, the process that needs to take place for that disclosure to take place, and for things to get implemented for your needs to be addressed. So I think, again, someone on this call mentioned it, allowing the spaces and these conversations to take place even before someone gets in front of you as their provider, I think is extremely important. Making sure on communications, whether they're paper or digital format, making sure that there is a little blurb saying, hey, if you would need accommodations, please reach out to us. Allowing this community of individuals to feel that they are welcomed into a space and that they have the ability to provide and advocate for themselves, I think goes a long way to hearing more from your constituents, your consumers, and hearing what their actual concerns and questions are and why they're coming to you. So I just wanted to put out there that, again, and a lot of times too, I will say individuals' disabilities also, it's a spectrum of comfortability, for lack of a better word. Some individuals have great expertise and knowledge and understanding of how to advocate for themselves. Others don't. Maybe this is something completely new to them, or they need other individuals in their support team or system to help advocate with them. So again, allowing spaces and clearly, I guess, the only term I can come up with right now is marketing the ability for that to be possible, I think is really important.
Thank you, Megan. So I totally agree. The importance of just having a way or approach to be able to get this information and reduce some of the fatigue and feeling like we have to keep reminding people. But one thing that we have recognized is that the indirect training as a result of informing our healthcare system and having a system in place, providers also start to recognize that, I never really thought of this, or I didn't really realize it. And it helps them to become more attuned over time. So that is one thing that I have recognized by doing this. And we have a long way to go before we can make this standardized and systematic in terms of our approach, but we'll talk about some tools. We do have a request from Samantha. She would like to make a comment, so we can let her make a quick comment before we move on to our second question. Samantha?
Hi, can you hear me? Yes.
Yes, we
Okay.
can hear you.
Okay, perfect. Thank you so much. I just wanted to join for a few minutes today just to mention something. My daughter, she's deaf with bilateral cochlear implants. I'm a Michigan Medicine employee, and I've been working at trying to get clinics to either utilize clear masks when interacting with her, or I've also brought up not using masks with her, especially in the setting of speech therapy services with Michigan Medicine. And I've just encountered a lot of roadblocks. The clinics often don't have clear masks available to use with her. She cannot understand what providers are saying to her, nor can she read lips without clear masks. The masks muffle the sounds for her. And so I'm just trying really hard to get clinics on board with having these available, or to have alternative options in the masking policy for DHH population, especially, my daughter, she has a limited lexicon. She's learning how to hear and listen. So I just find this very challenging. She's not able to interact with her providers in an appropriate manner.
Yes, sir. Thank you so much for your comments, and we're going to just pause, allow for the interpreter to go ahead and switch. Okay, looks like we're all set. Samantha, you raised a really great point about the need for, again, like ClearMap as being one tool that we should be widely implementing. So again, why couldn't we just have that be our first approach rather than just devoting in a very inaccessible map and waiting till we get these requests? So there has been a lot of effort across Michigan Medicine to make sure that these maps are available. There are 2 that are approved as a vendor where we can actually purchase it. I know it's so inconsistent. And again, this is a great reminder for all who are watching to hopefully champion at their departments and their various programs to make sure that we have not only used it, but maybe you can also just implement that to be your default mask rather than waiting to somebody ask. We do have, and I'll show you shortly with the Disability Accommodation tab where we have it, where if there's a need for a clear map, that request can come up. And there are certain exceptions. For example, if somebody is on oxygen or has other respiratory needs where that map exception can apply. I know we're moving a little bit past from the pandemic stage to now where map is optional for patients. So thank you for that feedback.
If I could jump in, Mike, just to respond to Samantha too. I would encourage Samantha to also elevate this concern to the Office of Patient Relations and Clinical Risk, and also to my office. You did?
Yes, I
Okay.
did.
And then I would also follow up with the clinic to help ensure that there is an accommodation provided. One of the barriers that we have as an organization this big and complex is a lot of times it kind of falls through the cracks, it's really a unfortunate incident when we can have an easily fixable accommodation like that, when it kind of gets disregarded by a clinic simply because they don't think it's that important, I think, or they ignore it. But it's an obligation that we do have to do to ensure that that the accommodation is being provided to your daughter.
Yes, thank you so much. I did report this to patient safety and clinical risk. They sent me a letter and without really any adequate responses, in my opinion. And my primary concern is actually that the clinic that most frequently uses the regular masks is actually the Hearing Rehabilitation Center. So, which is confusing to me because they should be very well aware of these issues, since they exclusively work with those who have hearing loss. There is a clinic, I think it's like a family medicine clinic for patients who have hearing loss. It's like a tertiary center, and they exclusively use clear masks, at least that I'm aware of, but I've heard from other people. So yeah, I wish, other clinics would follow the same strategy.
I would suggest that you and I take this offline and talk about this at some other point to see what we can do to ensure that this doesn't happen in the future. I'm not sure there's a way for find your unique name and contact you offline to discuss this further.
I could put it in the chat.
Okay, thank you.
Thank you, everyone. So again, this is an example of the Safe and Clear. This is one of the approved maps that we do have. And I totally agree that it's really critical just to ensure accessible communication. And that is not just for deaf and hard of hearing individuals. We have noticed that others, whether it's intellectual, developmental disabilities, a lot of people also like to be able to see faces. Children like it. It's also less intimidating. So this is not just for one subset, but actually applies to many. And there was a study that was interestingly done at Duke or University of North Carolina using these clear maps, even for just the hearing population. People reported better patient communication and better connection with their surgeons. So again, if we're committed to improving satisfaction and outcomes, I think this is the way to go rather than trying to look and see if we can locate these clear map. So thank you for the comment, and we'll, sounds like Matt and Christa will be able to follow up on that. So I want to, just for the sake of time, move on to our second question. So this is a question for both Matt and Megan. Why do we need to address these health inequities and these barriers, especially facing patients with disabilities? Why is it important?
Well, I think, first is the right thing to do to ensure that our patients are getting access to healthcare, regardless of their particular traits or what personal characteristics they might have. In this case, disability. But it's also the legal requirements for us to make an accommodation for a patient when it's requested. There is a provision in the Affordable Care Act called Section 1557, which reinforces non-discrimination in healthcare. And the reason for that is that with more people in the market receiving health insurance, there is a concern that with more consumers, there's going to be amplified health disparities. And to ensure that that is mitigated as much as possible, that's the purpose of the regulations, to ensure that access is provided to patients. And like you said, Mike, and when you started off the conversation, there are certain barriers that arise when it comes to disparities. So there's a lower use of preventative care, so more things like cancer screening or immunizations or eye or dental examinations. It couldn't go on more and more. But there's also the potential problem for misdiagnosis, increased testing, and increased hospital stays for patients who don't have access. So while it's the right thing to do to ensure that we are providing services to our patients, regardless of their background, it's also the legal requirements for us to do as well.
This is Megan speaking. All wonderful points Matt said beautifully. And I'll just add to mention that this might be a new concept for some, but for those that know, universal design, right? Universal design is a concept that really at its base foundation is looking at the environment, looking at everything around us and trying to accommodate for the most individuals as possible. And by accommodating for and creating an environment that's fully accessible as much as possible, it then accommodates hopefully the majority of multitudes of various diverse individuals. The example I'll use that just comes readily to mind to help hone in on this concept is curb cuts. When those are sidewalk ramped pieces, right? The curb cuts. Those were originally, I believe, instituted for strollers and for mothers with strollers and carriages and stuff like that to help get onto sidewalks. Well, that obviously universal design aspect now is utilized by multitudes of different populations of individuals, including our individuals with mobility or visual impairments as well. There's various different components usually to those curb cuts you'll see that have the little bubbles on them for our visual and low vision and visually impaired individuals. So again, by making that one change, it has actually opened up and made the ability to walk on that sidewalk to then get to where your destination is more accessible to the larger public, to the larger population. So I think in all of Matt's points as well is by providing access and accessibility and thinking about this broadly, we can then hopefully fold into those individuals that need those specific accommodations as well. And we need to address this. Why it's important is honestly, I always love this fact is that the disability community is actually the largest minority or marginalized group in the entire world. Because not only does it include those individuals with disabilities, It encompasses race, gender, ethnicity. It encompasses every other possible identity that you could think of, social economic status, etc. So very much these are your patients. These are your friends, your family, your neighbors that are coming to you for support, for questions, for concerns. And by really honing in and being able to create access for these individuals to come to you is wonderful, because again, this is a huge population that actually will just continue to grow as we are in the baby boomer phase coming, to their older age and stuff like that. This population, the disability community will continue to grow, because we also have made lots of improvements in the medical community, in the medical field, to help with diagnosing with support and resources. So more of these individuals will hopefully be coming to you, but we need to still make sure that door is as fully open, as accessible as possible.
Thank you so much, Matt and Megan. So this really is a perfect time to just jump back on some slides and some of the approaches that we're doing here in Michigan Medicine, and we continue to need your support to make sure that we're doing it widely. So give me 1 second here. So again, we talked about why it's important, and we've already heard several reasons for it. So here in Michigan Medicine, we often refer to the base, which is talking about belonging, inclusion, and we want to make sure that we have an environment that's we've heard about being comfortable. We want an environment that's also anti-racist, inclusive, improve healthcare equity, and reduce health disparities. But this also should include anti-ableism as well. And when we talk about access, we want to make sure that access is not only getting to the appointments, but getting the appropriate care, getting an equivalent care, just like somebody that might not struggle with these access issues. And then safety and quality, we want to have a high reliable culture, again, focus on addressing many of the inequities that have already been documented in this population, and also reducing some of the employee and patient harm. Keep in mind that also our providers, staff, and even learners want to do the right thing, and we need to make sure that we appropriately equip them to be able to do that. And then experience, we want to improve patient, family, employee experience with the focus on engagement and wellness in our communications and actions. And that also needs to include people with disabilities. So in order to do this, one of the major efforts with the Disability Council and also for the Center for Disability Health and Wellness, we have an accessibility task force. And so again, the big need is we need to know who are the individuals who have a disability and what accommodations or needs that they may have. So how do we do this? And we felt the importance of making sure that we have a standardized set of questionnaires that patients, staff, providers, caregivers can all report, and it also can be appropriately stored and saved in an area in the medical records so that all of us can see and try to be proactive in meeting the needs for these accommodations. And so this is a QR reader. If anybody wants to just take a quick snapshot, we can also share these slides. These are also available at the Center for Disability Health and Wellness website. So I encourage you, if you have not come across this or you're not familiar with it, please check us out. So this is a MiChart feature. This is part of the Epic medical record system. So keep in mind, Epic is the largest electronic healthcare record sort of software provider. And so we're excited to have this feature. And this is, as far as we're aware of, we're the first academic medical center that actually does this. So we are a pioneer, which is unfortunate that we're still, a pioneer. But again, we want this to be widely implemented, and we're encouraging other systems to get this set up. The good news is that there are several systems that have already engaged us in learning from this and now are in the process of adopting something like this at their academic medical systems. So in the MiChart, if you were to go to your provider, or if you're a provider yourself, there's going to be a patient storyboard on the left, and you'll see under the names, there's a couple basic information, including pronoun, gender identity. Right under that is the disability accommodations. So if you were to select that left side, it will populate this field that we see in the center, and it will actually have level 1 and level 2. Level 1 is the disability categories, and level 2 is the common accommodations or needs based on what you select from the disability category. So in this case, CDR mock patient here actually identifies being hard of hearing, deaf or deafblind. And when that was selected that there is a need for captioning, also to make sure there's a clear map. We heard the importance of that earlier, and a quiet space for communication. So the intent of this is actually to not only identify these individuals in which we have to make sure that the communication or the accessibility is addressed, but it helps to also proactively meet the needs. So have an upcoming appointment, we can try to make those arrangements and meet the needs of these individuals. So the other important thing I want to just highlight, the Center for Disability Health and Wellness has a whole bunch of resources, tip sheets that I encourage you, if you're a provider or a staff member, or if you want to provide it to your provider, I encourage you to check this out. One thing is many healthcare systems feel meeting the needs of these individuals, it's too cumbersome. We already heard we need to do it anyway, but I will also highlight that the vast majority of these accommodations are actually pretty easy to meet, and they're also low budget. So we need to move away from this notion that it's always cumbersome, too difficult, when in reality, most of these are just being aware and simply act them. So I'm going to now go ahead, turn over and ask our panelists. So what else can we do to address the existing access issues and the inequities that we see with patients with disabilities? You know, obviously this could be how we can leverage that MiChart disability accommodations, but are there additional strategies that you would recommend? Christa, would you like to go ahead, start first?
Absolutely. Number one, definitely check out the MiChart disability tab and see if it's been filled out. And if it hasn't, offer that when you are talking with the patients that you're working with, seeing if they're aware of it, if they would like to fill that out either with you, or also they can do it through the patient portal. They can go into the questionnaire through the patient portal, so they can do that privately. The other thing I think it's really important to be aware of is, you know, when people think about disability, a lot of times they think that it is something that, oh yeah, I know what a disabled person is, or gosh, I didn't realize that we had that many people in the United States with disabilities. Where are they? Well, the answer is they're right in front of you, and they might even be you. The numbers are really 80 to even as high as 96% of those 1 in 4 Americans who has a disability, it's an invisible disability. So thinking about things like the number one being mental health, right? That is going to impact someone's interest or ability or willingness to be able to participate in their own healthcare. You know, we talked about someone who might be hard of hearing. Just across the board, people on the spectrum. I mean, everywhere, 80 to 96% of these disabilities are invisible. The last thing I wanted to mention too is, and truly, in my position, very often I'm kind of the fly on the wall. I do a lot of observing. So, you know, look around your clinic and maybe pick a topic and think to yourself, either talk to your patients maybe who have low vision, or think to yourself, if I had a patient today at 8 o'clock this morning who was blind, how would that patient get here? Might there be delays in their getting here? What happens when they arrive and their transportation drops them off at the front of this giant hospital? How would they find their way to my clinic? And then how could they best independently interact with us, find a place to sit, all those things that are required of a patient who doesn't have that particular disability, and think about what it is that your patient, your clinic could do, or you could do to try and mitigate some of those issues. And because it's not one size fits all in a clinic either. Every clinic is going to have a different structure, different, workflow, whatever. But truly, it is the responsibility of us to be able to really be proactive instead of waiting until they have to go to Matt or Megan or file a complaint with patient relations, but to truly say, what can I do proactively by just simply opening my eyes and going, wow, this clinic is incredibly crowded with chairs. How would somebody or two people in a wheelchair be able to be in this room and engage with me as a provider, or wait in our waiting room without feeling like they're blocking everybody? So open your eyes. You've got the power to make change.
Thank you so much, Christa. Alex, any other insights you'd like to share?
This is Alex. One I thought or topic that had come up, I know in the previous discussion, was just related to cost. And I think recognizing that accommodations are not always expensive is an important thing, because I think that can be a block for people before they even start going down the road of trying to accommodate somebody that they're working with. And just being open-minded and creative and flexible as far as those accommodations go, because there's many ways to solve a problem oftentimes. And again, trying not to limit yourself into thinking what those might be is really important in terms of supporting somebody and meeting their needs.
Thank you so much, Alex. Any other comments before we move on? Okay. So the one other thing, so we do have a question here. What about patients from marginalized ethnic communities? Were there any on the panel? And I missed it because I was late. So I think that raises a great point. And it also highlights the importance of any efforts around DEI. We want to make sure that we also add DEI and accessibility. So diversity, equity, inclusion, accessibility. Sometimes people with disabilities are often forgotten in those areas. And then as part of our grant, we also recognize that those who come from racial ethnic minorities are also more likely to have a disability. So I appreciate the comment, and I do agree that we do need to make sure that we continue to try to be more inclusive and engage those from those communities. So thank you for that comment. And the one other thing I just wanted to highlight in terms of how we can address this is really the need for training. So unfortunately, even in medical school, health professional schools, there are very, very little training around how to engage, how to care, and how to communicate effectively with patients with disabilities. And so we have a disability health elective here. And so we're trying to build, but these are really, again, elective. These are not mandatory class-wide type of courses. And so further change needs to happen there. And in the same area is making sure that we have mandatory courses for those that are on the provider and staff level, so that we can try to address some of those training gaps. Unfortunately, me as a provider and looking back in medical school, and I often ask this question for many of our medical students: how many hours did you receive around disability health? And, not surprisingly, the numbers will range anywhere from 0 to 3. I have yet to hear anybody go beyond 3. And so this is talking about 4 years of medical education. And we've already heard that this is the largest minority group, yet we have very trivial, if any, at our health profession training programs, which is unfortunate, and that has to change. So the next question for all of us here is, how do we support this effort in terms of trying to make sure that we have accessible healthcare? How do we address many of the findings around health inequities for people with disabilities, including those who are marginalized populations? And we talked about some examples like support, funding, training, but I'd like to open it up. What would be sort of key areas so we can hopefully move forward. Who would like to go first? Matt, you had your hand up first, and then Megan, you could be second.
Right. Well, I think a huge concern is simple awareness of what an accommodation is and what does it look like. I think a lot of times, there's an accommodation request being made, and the clinic or provider or whoever's involved with it might just dismiss it as just a comment or a suggestion the patient's making, and not really the required communication that's required to ensure that there's a discussion going on between the patient and the unit or the clinic to ensure that there's access being made. So I think a huge concern is simple awareness, and that could be a low bar, but I think that from what I've seen, I think things could go a lot easier and a lot more efficient and effective if people just realize that this is an actual request that the communication is required to have. And I think training is an important part of that to ensure that that our staff knows what this looks like when it happens.
Megan, thank you.
Yeah, and just this is Megan speaking. To add to Matt's point, I think the awareness is awesome. And then to add that awareness, a lot of people, if you don't have that awareness or you're not sure the next steps to take when there is that disclosure that takes place of a request or a need for an accommodation that you're hearing from a patient or one of your constituents, is to know the resources, right, that you can go to next, right, who have those answers, who can help support you and your patients. And really, there's a whole host of them, but Matt and I know are definitely two of those entities that can very much help with questions about, hey, I received a request for an accommodation from a patient, not sure how to approach this, what needs to happen next, et cetera. I think a comment just came in.
Can I just quickly add to both? For the most part, I have not seen people at Michigan Medicine, staff or faculty, actually purposely do something to not provide access. It was more a matter of not knowing in advance, being stuck in the moment, and kind of being shocked as into not knowing what to do versus not wanting to do it. So that's where this knowing in advance is so key, being proactive, being so key, and that education and training, I think. Again, I know people want to do the right thing. And so it's just a matter about providing the training and having the knowledge in advance to be able to do the right thing.
This is Matt. I just want to add on to Christa's comment too. I think you mentioned before, Christa, that the part of the problem too is making assumptions. And it could be done with the best of intentions, but it's not the best or the correct way to actually go about providing an accommodation.
Thank you, everyone. Any other comments before I know we have a comment in the chat. Okay, we're going to turn over, just give a second for the interpreters to switch. Okay. So we have a comment here. Are there any guidelines we can follow to help our call center and staff learn to ask about disability and fill out the accommodations tab? That's an excellent question. It's definitely a wish list. This does raise the importance of understanding that this needs to be a priority across the institution. So we do need to make sure that our leaders also prioritize this and disseminate that to our entire team. So that is something that has not been fully implemented yet. And also it's important to understand that disability is not just specific to disability champions or disability friendly clinics. All of us are responsible to making sure that we provide equitable and accessible healthcare for everybody. So as of this moment right now, they do not have a sort of a protocol to incorporate that. We are working on that. So if you have any additional insights or key personnel that can help us with that, we would love for your feedback. But it is definitely on our wish list. One thing I will add, though, is that we are also highlighting that there are certain clinics. So right now, OBGYN for one clinic and also across all of the family medicine clinics, there is a automatic send out for the portal questionnaire. So the portal questionnaire actually incorporates that Disability Accommodations tab that that just showed you a few minutes ago. So people are getting it as part of their e-check-in. So they receive this prior to their appointment, which is helping to move things a bit forward. Certainly we need to do that much earlier. We also need to make sure that is part of the protocol. When a person schedules the appointment, that's the perfect time to start obtaining the information so that we can appropriately meet their needs. And so that is one step that we're doing right now is the portal send out, and that is available. Anybody could send that out. Any other comments about the call center or other strategies? Yeah,
To that, just for everybody knows, these fields are being filled out. I don't know what the numbers are right now, but that means that if someone takes the time to fill this out to let the clinics know, that you all need to start checking because you know somebody might be disappointed if they don't get their accommodations met prior to having done that and fill that out. But once they fill that out, there's going to be this expectation like, wow, I've gone ahead and filled this out. Now they know to provide clear masks. Now they know I need an accessible scale. So that person is going to be quite upset if they've gone ahead and done this and no one has looked at it or they're unaware of the fact that these requests have been made. So it's there. Look at it and we need to start making these accommodations now because they're being asked of us.
Thank you, Christa. Are there any other questions in the chat? And while we wait, I do have a question for Alex. So one of the key things, and we talked about the lack of training, and certainly people don't understand some of the resources that are available for patients with disabilities. Could you provide us a bit more information on how providers, staff, caregivers can reach out to organizations like yourself and also for the Michigan Network?
Yeah, sure. So first I think it's important to say there are lots of organizations out in the community that are working with people with disabilities in a whole variety of different capacities. I can obviously be biased to Centers for Independent Living, as that's where I've worked for so many years now. And folks can just reach out to any Center for Independent Living in the state, either by calling them or through email, sometimes web chat. The easiest place to go to figure out where one individual Center for Independent Living might be, because there are 15 here in Michigan, would be to go to the DN Michigan website. So it's just dnmichigan.org. And you can figure out where your Center for Independent Living is geographically and give them a call. But with that said, there are a lot of other organizations out there doing some great work. Detroit Disability Power is a great organization that's doing a lot of advocacy work out in the community. There's United Cerebral Palsies, there's ARCS, just so many different groups out there right now. And each one of them has its own specialties, its own areas of expertise. And hopefully, if we're all doing our job right, we can get you to the right place and connect you to the right folks.
Thank you so much. So we do have a question here, just a clarification. Patient completes the accommodations questionnaire prior to visit electronically. Yes, there's different ways. So currently the Disability Accommodation tab can be filled out in person by a staff member provider. Here at our clinic, we do often give out a paper copy. Not everybody has portal access. So that is another avenue in which they can fill it out, and a staff member can upload that information into the chart so that we have that information going forward. The portal is available for anybody who has a portal. The majority of patients here in Michigan Medicine do have portal access. Not everybody uses it fully. So we want to make sure that we have other strategies to be able to capture that information. So the e-check-in I was talking about is usually sent out 48 to 72 hours prior to the clinic appointment, and they can fill that out to have it available, and then the provider will be able to see that information. Ideally, we like to do it earlier, even at the time when the appointment is scheduled, so we can have even more time to get things set. Okay. Are there any other questions or comments from our panelists? Appreciate everybody joining today. Okay. So for those of you attending, please check us out at the Center for Disability Health and Wellness. There's a lot of resources here. Also, Sarah was able to post, if you can go to their Disability Network in Michigan, lots of resources, community resources there. And we do have another, looks like a really great conference here, be able to connect with the African American Conference on Disabilities. So I'm going to definitely check that out because I know our grant is looking at, especially for marginalized communities who have a disability. We are very interested in looking at additional strategies, approaches to be able to work with that population. So thank you for sharing and posting that to everybody. Last but not least, I want to thank our interpreters. So Christine and Helen, thank you for joining, and also our captionists and for joining as well. So if there's no other comments, we'll close a few minutes early so everybody can transition to their 1 o'clock appointment. Thank you, Matt, Megan, Alex, and Christa. Thank you for being a part of our panel discussion today. Thank you so much.